Okay, good afternoon, everyone, and welcome to the 2021 Global Health Symposium. Our theme for this year is Disparities in Mental Health Delivery, Past, Present, and Hope for the Future. It's well established that socioeconomic disparities can lead to mental health issues, and that mental health issues can lead to greater socioeconomic disparities. As healthcare providers and systems, what can we do to help break this cycle? This year's symposium will take us through a historical tour of the evolution of mental health as a field, help us understand the current healthcare system of incentives in our own country and how this has contributed to disparities in access. We will also be looking at the state of mental health care globally. We are delighted to have speakers who not only understand how we have come to be where we are, but who are also innovating practices to address these disparities. I am very pleased to introduce today's speaker, Dr. Fernando Espeforsen. Dr. Espeforsen, MD, PhD, is a psychiatrist at Mass General in Boston. He was an assistant professor in the Department of Psychiatry and Behavioral Health Sciences at Rush University from 2015 to 2020. Dr. Espeforsen's research interest is in the history of psychiatry, and his PhD dissertation was titled Demons, Fast, and Death, which looked at the state of mental health in the 13th and 14th centuries. He has multiple publications in medical journals in this area as well. His current research is focused on insanity assessments made by the physicians hired by the Spanish Inquisition in the early 17th century to differentiate heresy from madness. A paper related to the topic was published at the Journal of the American Academy of Psychiatry and Law. In addition, Dr. Espeforsen hosts his own podcast titled El Último Humanista, which focuses on psychiatry and the humanities. And he's been a guest speaker on other podcasts in the US and Spain. We are delighted to have him here with us today. We're going to have some time at the end for questions, so please feel free to write your questions as we go along in the chat box, and we will get to them at the end of the talk. The title of today's talk is Understanding Current Disparities in Mental Health, a Historical Perspective. Dr. Espeforsen.
Well, thank you very much for the introduction, and I think I'm going to go ahead now and share my slides. Okay. So, well, thank you, Dr. Crane, for this nice introduction. I was at Rush for 5 years, and I was one of the teachers there. So I guess I met many of the students that are today at the presentation. So it's very nice to see you again. And thank you, Dina and Oscar, for helping also with this presentation and the preparation of this presentation. So it's very nice to be back at Rush virtually or quantically or whatever we want to call it. And I've been here for 5 months, and I really miss the familiarity of Rush. I think it's very meaningful for me to be back here. So last year, we're going to do this talk, but we're going to focus more on the history of psychiatry aspects. But in conversation with Dr. Crane, we decided, let's talk more about the current disparities and how can we relate our current problems in mental health and equality in mental health, and how can we understand this from a historical viewpoint so that we can get more sense of the narrative, like we do in psychoanalysis, like we try to get the narrative so that we understand where we are. So we're going to try to get this narrative so that we understand where we are right now. So we're going to talk about understanding current health disparities in mental health, and we're going to offer this from explaining from a historical perspective. So first, let's talk about the patient I saw at Ross, but we see these patients at Ross. I used to work in the ER when I was at Ross. I used to do psychiatric emergencies. And this is just a sample of a patient that we normally can see in the ER. This is a patient that I saw, but I'm sure most of you who have done rotations in the ER have seen a very, very similar situation. So this will be a 30-year-old person who presents to the ER. He has suicidal thoughts. He's homeless. He's grieving the loss of his girlfriend. The urine toxicology is positive for opioids. He claims to have been diagnosed with bipolar disorder at some point in his care, but he doesn't quite remember. And right now, he has no psychiatric care and no engagement with any psychiatric care whatsoever. Then on review, we find out with the help of our social worker, the patient has no insurance, and the plan, because the patient is still suicidal, has to be transferred to Madden, which is the state hospital in Illinois, in Chicago area. After 36 hours waiting in the ER, the patient is tired of waiting in the ER. He starts to feel better, and he asks to leave. He starts to contract for safety, and we discharge this patient on a combination, for example, on fluoxetine and quetiapine for the treatment of this bipolar diagnosis, and a photocopy indicating the different walk-in clinics that he can go to if he decides to pursue further care, because we don't have access to anything else. We would recommend partial if we could, but we can't. We would like the patient can go to Madent, but the patient has been waiting already 36 hours, and sometimes they wait even longer. We would like to make an appointment within 1 week, but we can't because there is no access to care if you have no insurance. So we would like to do all these things. We would like to refer to a substance abuse clinic, but we can't because the patient is in the ER. So all we can do sometimes is just give a photocopy and say, hey, if you want to continue your treatment, this is the appointments that you can go for a walk-in clinic. This is a patient that I saw multiple times. I'm not talking particularly about this patient. I saw this multiple times. I would say almost weekly. I saw that when I was working in the ER. Was this optimal psychiatric care? You know, if we follow the recommendations, we have recommended inpatient, de-escalation to partial hospitalization, intensive outpatient, but this is something we can no longer offer because from the public system, psychiatric care, we cannot offer that. Only people who have insurance, only people who can afford it are gonna get the recommendations that we normally recommend by guidelines. So what are the current challenges in mental healthcare in America right now? So first, we have lack of access for all, as we just saw in this patient. Mental illness make you prone to poverty and to eventually get no insurance. It's very hard to have a schizophrenia or bipolar or severe opioid use disorder, have insurance, because in order to have insurance, you need to have a job. And it's very hard to have a job when you have severe mental illness. So mental illness is a public health issue. It's a public health issue, I mean, nowadays. So most of the people who get optimal mental illness care are people who have insurance, who have a job, and it's very hard to have severe mental illness and have a good job that gives you a good insurance. So this is one of the main problems we have in the United States nowadays with the current system of care that we have. Also, there is a limited number of days. Even if you have insurance, admissions used to be 3 weeks, which is how much do you need to treat somebody who has suicidal ideation, providing psychotherapy, providing psychopharmacology. According to research, for psychopharmacology, you need 4 weeks or 6 weeks. But usually the insurance only approved for 7 days. So in 7 days, you had to figure out the plan to decrease the risk. Also, inpatient psychiatric stays right now focus primarily on safety. You know, we want to make sure that during the next 7 days you don't commit suicide. So we're going to be watching you every 15 minutes. We're going to remove all the items that you could use to commit suicide. But overall, are we improving quality? Are we providing nurturance? Are we providing quality care? Are we doing appropriate psychotherapy? Are we allowing the patient to get good care? You know, being in an inpatient psychiatry unit is something therapeutic nowadays, is something helpful. And I'm not criticizing Ross. I'm criticizing all inpatient psychiatric units. Myself, I work right now in an inpatient psychiatric unit, and we continue to have similar problems. So we're limited by number of days. The experience is not quite pleasant sometimes being in an inpatient psychiatric unit because we prioritize safety so much that we remove art therapy, we remove getting out of the unit. The units are locked down. There are no open air spaces. There are no green spaces. So all these things we are missing now during a person that is suffering the most. We are making sure that the person doesn't commit suicide or is safe, but at the same time, we are not providing nurturance. So it's something we have to think about as well. There is an equal access to transitional programs like of partial, like for this patient, the patient was no longer suicidal, but the patient was suicidal a day before. So ideally, we should have offered partial, but we couldn't because the patient had no insurance. So in the end, we just gave him a photocopy for walk-in clinics. So no access to partial, no access to intensive outpatient programs or to appointments for that. There's less and less in public investment in mental health right now in every state. This is a problem that happens in every state, particularly in the Midwest. I think it's more problematic, but it's happening in Massachusetts and many other states as well. So there is lack of time in clinic. There is a lot of reliance on liability and documentation, safety documentation, liability, but that takes away time to provide nurturance and care to the patient. The quality of time with the patient is reduced. The quality is reduced and the time is reduced. So less time and less quality care because you are trying to focus on trying to get as much information that you can to fill that template that is required by insurance, that is required by the safety standards, the quality standards, and so on. So the system is very neurotic, but at the same time, I don't know if it's being effective for nurturance. Nurturance is something that we are sacrificing all the time. You know, instead of having spontaneous relationships, more dynamic relationship, leaving more space for creativity in the care of the patients, we are focused on the pragmatic guidelines that they have been given to us and we just execute without being creative, and sometimes we treat everybody the same regardless of their symptoms or their unique circumstances. We have also in clinics, there is less time and there is more reliance on psychopharmacology than psychotherapy, when we know that if we were suffering, we would like more psychotherapy than psychopharmacology at first, but then we cannot provide that. So there is no time for talking, there is no time for therapy, and we just give medicines, but there is not even time to engage the patients into taking their medicines sometimes. So these are common problems that as psychiatrists, we see common, relatively common. I'm not trying to be highly critical. I want to be constructive. I just want to just express the emotions of most psychiatrists nowadays. There are lack of new medicines that are more effective than the ones that we have in the 50s and 60s and 70s. Maybe they are safer for side effects sometimes, but they are not more effective. And there are also frequent misdiagnoses because the way we make the diagnosis is sometimes we require by the insurance to put a psychiatric disorder diagnosis. And often people get severe mental illness as a diagnosis. And that allows you to prescribe more medicines, but there is no understanding. There is no time to have a good formulation of the case for diagnosis. So I think there is a lot of variability in the way we diagnose in psychiatry. So sometimes one patient see different psychiatrists and get different diagnoses depending on the psychiatrist that they have visited. So these are problems that we have as well, and also the stigma that is a problem that psychiatrists repeat all the time to get people to access mental health care resources. So let's review a little bit of the history briefly, and then we go back to questions and thinking. So mental health care until the 18th century, including the United States, was impacted by Greek medicine. So as we know from the history of medicine lectures that you guys got, we have the classical treatment that is considered the Greek or Greek-Roman treatment, which is Hippocratic medicine. So they classified all different diseases as a disturbance in the 4 humors in your body. So as a result, also mental illness was considered a medical problem that was resulting. It resulted from a disturbance in the 4 humors in your body as well. And as such, you could have mania or melancholia. Mania was not like mania nowadays in bipolar disorder. It was a wider sense of mania. It was anything that can cause agitation, anxiety, uncontrolled rage. All that was mania. So in that, according to today's classification, we'll have things that are like schizophrenia with paranoia and agitation, mania with paranoia, classic bipolar mania, anything that causes agitation and increase, exaltation, hyperactivity, etc. Melancholia was a decrease in the functioning. So that could be depression, it could be schizophrenia with negative symptoms, but that's how we understood mental illness for a long time until the 18th century, if we follow the Greek-Roman model. Nonetheless, with the triumph of Christianity in the Roman Empire and the beginning of the Middle Ages, gradually spiritual approaches were used as well. So if Jesus did exorcisms for people according to the Gospels, this could be also a treatment. So the priests in the churches during the Middle Ages in Europe, they could use this treatment, like exorcisms, for treating mental illness as well. There was a little bit in monasteries, people keeping the Hippocratic medicine as well, so that continued to exist. And there were medical plants as well used in the monasteries, but also spiritual treatment was very prominent as well. Nonetheless, I don't mean that spiritual treatment is not good. Nowadays, we have chaplains that help our patients with mental health problems or medical problems as well, and this can be very helpful for patients as well. And if we think about it and we put things in the historical context, what could be a better treatment for a person in the Middle Ages than an exorcism down by the practice by the priest of the town. For somebody who has neurosis and anxiety, it can definitely have a psychotherapeutic effect. So it's good to be flexible also about these ideas, because sometimes spiritual treatment has been seen as something that was negative. And I think for that society, it was something that was probably more effective than some of the medicines that we use nowadays. In contrast to Europe, in the Islamic world, during the Middle Ages, they integrated the Greek Roman medicine, and they practiced Greek Roman medicine in the Maristans. And in the Maristan, they continue to provide psychological and psychiatric treatment for patients following the principles of Hippocratic medicine. This is the Bimaristan of in Syria, in Damascus, that was bombarded now by ISIS, but now they are trying to reconstruct it. But this is from the 14th century. We recovered the Greek medicine actually through the Muslims. So it was in the 13th century that in Sicily and in Spain, people started translating the text from Arab into Latin. And then all the Islamic medicine, like Avicenna, the canon of medicine, and the Greek Roman medicine was incorporated again into the traditional Western world. And that's how we recover. So this is a very important thing, because we are inheritors of the Greek Roman medicine, but this is something that people don't understand so well, that in the Western world, we are inheritors of Islamic medicine. The canon of medicine by Avicenna, that used an Aristotelian classification for diagnosing diseases, like by diseases of the heart, diseases of the liver, diseases of the lungs. This is how we classify specialties nowadays, like pulmonology, or cardiology, etc. We are inheritors of that by the canon of medicine by Avicenna. And the canon of medicine by Avicenna that was coming from Iraq, from Baghdad, and this canon of medicine was the standard medical textbook until the 18th century in all Europe and United States as well. In Europe, after this, in the 15th century, we started to open hospitals that are specific for the treatment of the mentally ill. And the first hospital that opened, that we know that is specific for the treatment of the mentally ill, is the hospital in Valencia, which is called the Hospital of the Innocence in Valencia. This is the door of the hospital in Valencia, and it was founded in 1409. The interesting part of this is, like most of the hospitals in Europe are funded by religious organizations. So the Catholic organizations and the Catholic groups, out of charity, they organize this. So this is the closer thing to a public system that we had. Because in the Middle Ages, we didn't have a republic. We didn't have democracy. So we had the monarchy. And the monarchy allowed institutions to organize charity the way they wanted. So the public system was offered by the church. And we're going to have that until the 19th century. So it's important to think about these concepts, because nowadays, when we make a claim that we want to improve the mental health care, we go to our politicians, right? Because the system right now is public. But at that time, people wouldn't go to the monarch. They would go to the church and they would say, we need to take care of these people. And it's offered the church. It was not negative for the care of the mentally ill. People would go to the monasteries to get care, people with severe mental illness. And out of charity, they were getting care and they were getting medical plans, etc. So that's how the hospitals in Europe were funded, and also most of the hospitals in America. This is a picture of the first psychiatric hospital. It was the term psychiatry comes from the 18th century, but it was the first hospital for the mentally ill in America, and it was in Mexico. It was funded in 1567. And it was founded by a Spanish soldier called Bernardino Alvarez. And right now, this place is a place for weddings. So if anybody wants to get married in the first psychiatric hospital of America, they can get married there. And then what happened during the Enlightenment? During the Enlightenment, we have a communication between Europe and the United States. So there is constant communication. So in Europe, we have the beginning of what was called moral treatment. You know, people said, there is not good enough treatment out of the charity by the church. And also during the Enlightenment, we have more political, by the politicians, more investment in the healthcare of individuals. So people say we need to get better care, but this has to be controlled by the government, not by the churches. So they come out with new ideas of charity that were coming from lay individuals, such as moral treatment. So we have the moral treatment of Philippe Pinel. Moral treatment is not like moralizing people, it's more like humane care of treatment. So it proposed that people had to live in the asylums. This is the moment of the creation of the asylums. And in these asylums, in these hospitals, they could live like in society in order to be reinserted back in society. So in these hospitals, they could have a church, they could have workshops, and they could get all this kind of treatment to be reinserted back in society. And this was lay investment. Sometimes public intervention, sometimes it was out of collection from charity, from the bourgeoisie and individuals. And this was happening in Paris with La Salpêtrière, in England with the York retreat as well. This was actually an initiative of the Quakers people. The Quakers or Quakers also had a big impact in the mental health care in Philadelphia, the Quakers of Philadelphia. And also Benjamin Rush. Benjamin Rush is the product of the enlightenment of this new approach to mental health care. And Benjamin Rush, who lived in Philadelphia, and he's buried in Philadelphia. You can see his gravestone in Philadelphia. He's wrote the first book of the treatment of the mentally ill in the United States. And because of that, he became the father of American psychiatry. And his image was used as the seal of the American psychiatry until very recently, of the American Psychiatric Association. But also our hospital, I mean, it's still my hospital, Rush. Our hospital was named Rush after Benjamin Rush because he was the only physician who signed the Declaration of the Independence. Also during this time, they started funding, following the moral treatment from France and England, but especially France. France, the model of Paris, was translated into America. So there is a constant communication between Europe and United States at this time. So the moral treatment was transferred here, and they opened the asylum for the insane, and that was later called McLean Asylum, because of John McLean, who gave all his money to build this asylum. It was like a rich person who gave all the money. And this McLean Asylum followed the moral treatment model of the time. Also, general hospitals in the United States start to open their gates for the care of the mentally ill as well. So when Massachusetts General Hospital was founded in 1811, this is the Bullfinch building that you can still visit nowadays. And the main thing was to bring more and more psychiatry. So Massachusetts General Hospital was funded with the idea also of providing psychiatric care as a public issue in the city of Boston. So the city of Boston was highly involved in the treatment of the mentally ill as well, who were many times homeless and having no resources, and nobody could provide care for them. In the United States, Thomas Kirkbride was a surgeon who was a physician, but also he became the president of the American Psychiatric Association, and he came out with a model of care of the asylum in the United States. So this asylum, American asylum, became the model that was applied to all the states in the United States. And this had a Gothic tower in the middle, following the Victorian architecture, a Gothic tower in the middle, and then stances on the side that had like a bat wing form. So you have different buildings on the sides to the Gothic tower in the middle. As we can see, for example, in Kankakee, this Kankakee nowadays, so this is in Illinois, and you have the Gothic tower in the middle, and on the sides you have the stances, you have the different buildings on the sides, and the people would live in the asylums. The patients would live there, and the idea would be to be in a retired area where they could get fresh air, where they can do gardening, where they can have workshops, where they can have the ideal care that they need in order to be reinserted back in society. That was the idea. That was the idea at the time. And you can still visit you have Mantino Asylum in Illinois as well, and in every state you have many of these Gothic revival Victorian era asylums that now architects want to protect as well, because it's part of the history of the architecture in the United States. For diagnosis, we used in Europe the model of Emil Kraepelin that have the psychiatric diagnosis, where he differentiated between manic depressive illness, schizophrenia that was called dementia precox, and so on. And this classification of diseases became the standard of classification of diseases or diagnosis in the United States after Adolf Meyer, who was from Switzerland, translated the work of Emil Kraepelin to English. And he was the one who started DSM as well, Adolf Meyer, who became the chief of psychiatry of Johns Hopkins. But Adolf Meyer, who was one of the most important psychiatrists of the United States, he also was the physician of superintendent in Kankakee, actually, in Illinois, and he denounced it, the fact that they were lacking funding and they had 1,000 patients for 4 psychiatrists. I mean, can you imagine 4 psychiatrists? He was one of the 4 psychiatrists for 1,000 patients. So this was related to the decline of public mental health care. You can have a very nice building, but you have only 4 psychiatrists for 1,000 patients. What kind of quality care can you provide there? So there was a lack of interest in society of give funding for the care of these patients. And that contributed to the negative image that we have now of the asylums in the world, in general, in the United States, but in the world. At the same time, Freud and Jung and Ferenczi visited Clark University, and this is the birth of psychoanalysis in the United States. So psychoanalysis became a very popular treatment in America during the 19th and 20th century, and many psychiatrists became interested in doing psychoanalysis. But who could afford psychoanalysis? Do the people with severe mental illness could afford psychoanalysis? So this became the treatment of high-functioning people who could afford going to private practice and pay a psychoanalyst. So we have now care of people who had neurotic problems, but they were high-functioning. But at the same time, the people with severe mental illness were completely deprived, or that was not something that could be offered to them. The most popular psychotherapy at the time. Also, what could people get in the asylums? They could get electrocomposite therapy. That is something that was discovered in the 30s in Europe, and that became very popular in the United States very soon. They have other treatments like insulin coma as well, but electrocomposite therapy is something that we still do. And also psychosurgery, that became very popular, but that was very popular in Europe for selected cases. But in the United States, this neurologist called Walter Freeman, he started doing this in all the asylums, and he started traveling in his van to all the asylums doing psychosurgery, lobotomy to everybody. So that became like something that it has to allow us to think about it, because it doesn't have to be like terror or bad. It's the way we think sometimes. Like if something seems to be working, before we are not conservative enough. We are very conservative for safety, but then we are not very conservative for treatment. So if a medicine is working, we just give it to everybody right away without thinking of the long-term consequences. And here, this is what happened. It will continue to happen if we continue to think that way. If something seems to be working, we just do it to everybody without thinking of long-term consequences. This is a lesson to be learned from what happened in the 50s and the 60s, that a lot of people that didn't quite need psychosurgery got psychosurgery. But I think this is a lesson that we might have to learn in the future. Like right now, for example, we are giving antipsychotics to the children all the time, and we are not thinking of the long-term consequences of children getting antipsychotics. They may get Parkinson's disease or tardive dyskinesia, and we are not quite thinking of that because we are thinking always short-term. It's something that as a society we had to think. Psychopharmacology became popular in the 50s, and very soon it made it to the asylum. So chlorpromazine was marketed as a chemical lobotomy, actually, and that actually decreased the use of lobotomy in the United States. And imipramine is the first antidepressant that was synthesized. Both of them were synthesized in France, but they became very popular in the United States very soon. At the same time, in the 50s and the 60s, society started to become highly critical of power, highly critical of the government. This is the time of the civil rights movement. This is the time of Vietnam War. This is the time of feminism. So people also started to criticize psychiatry as something that was part of the system and that was thought to be oppressive in a way of how people wanted to express their behavior and their emotions. So in Europe, you have people like Ronald D. Lang in England, David Cooper, you have Franco Basaglia in Italy that start to change the law because they thought that the care in the asylums was not good enough and they wanted a more humanitarian care. But I think part of the reason that the care in the asylums was not good enough is because lack of resources. If, like I said before, you have 4 psychiatrists for 1,000 patients and everybody is just sending the patients there, how can you provide good quality care? So this is the moment of what was called the anti-psychiatry. It's called the de-institutionalization. Kennedy started to take the steps. Ronald Reagan is finally the person who started closing most of the asylums. Thomas Szasz, who died like a few years ago, became the most prominent figure of anti-psychiatry. He was a psychiatrist from Hungary but he wrote many books in America, like The Myth of Mental Illness. And at that time, you could argue that mental illness was a myth because there was no biological evidence. Now we have biological evidence, but he argued that mental illness was a myth, that we were using it just to control behavior in society. These people, many times, they were not involved in patient care, and they had these very nice ideas that were very intellectual, but they were not overall effective sometimes to solve the care of some people, because getting rid of the current system of care by not replacing it by something better, is that something that we want? You want to get rid of the asylums, but how are you going to replace it? It's something to think about rather than just getting rid of it. I think society many times is very reactive, and they want to destroy what we have. But you want to destroy what we have to replace it by what? That's what you have to think about. Not to destroy it, but to replace it by something that can be more effective. And I would say rather than destroying it, it would be to shape it or to improve it. I mean, you don't want to destroy something. You just want to improve it. I think that's the way I would think about psychiatry. So the asylums got closed. The book of Ken Kesey that became a novel was very popular as well, and that allowed society to have a negative perception of asylum care. So they decided to try assertive community treatment. So all the patients were discharged, the asylums closed, and all the people with severe mental illness were supposed to get treatment in the community, and they were going to take their chances in the community with the new medications that we have. But how do we feel right now about that? I mean, you get a social worker, you get a psychiatrist, you can do outpatient appointments, you can live in a shelter if you want. We have new medicines that have less side effects, but they are not necessarily more effective, like SSRIs. We have new therapies, but these therapies, are they covered by the public system? Can you get CBT in the public system? A little bit of it, but at the same time, CBT, which is an American treatment, that is very popular in Europe. So we have this conversation between the US and Europe at the time. Or we have DBT for people who have self-cutting or borderline personality, and this treatment is very popular in Europe, and mindfulness and all these new treatments. But who can afford these treatments? We have a lot of neuroscience, but this is so far research, and this is happening all over the world. We have also incorporated some of the treatments from American slaves, like Santeria, and some of this folk medicine is now becoming popular in our society, in our Western society. We're incorporating also medicines from the Native Americans, such as psychedelics for the treatment of psychiatry, ayahuasca, psilocybin. These are treatments that we are incorporating, and now we are trying to live in a global health culture where everybody is trying to be included. But at the same time, we have to start thinking, what are the current problems that we have? Why do we have to think that everything is always better than what we had before? Right now, when you go to an inpatient psychiatry unit, people don't have access to workshops, they don't have access to agriculture, they don't have access to green spaces, they don't have access to spiritual treatment sometimes. I mean, sometimes they do, sometimes they don't. They don't have access to psychotherapy very often. So is this good? Is this better than? So we can take some of these ideas from the past that may allow us to think about how can improve our current challenges, because some of the things that we did in the past actually would be interesting to reconsider for now on in a different way. Maybe it's not, I think it's not adaptive that we say the asylums were bad, ECD was bad, everything that happened there was bad, and now we have assertive community treatment. I don't think that's very good to think that way. It's better to just integrate all the history and see how we can improve it, because otherwise we're just going from one side to the other, one side to the other. But overall, we have a fantasy that we're improving things, but we are not necessarily improving the things. And I just want to say this in a very constructive way, not in a way that psychiatry is good or bad. I don't care if psychiatry is good or bad. I just want to provide better care. I just want to be effective. I just want to be helpful. I just want that in the future I'm not heavily criticized, but I think for that we had to be fair to the past and we had to be fair to the present as well. So we just want to make things better. So we had to think that's assertive community treatment, outpatient care, provides the needs for the patients with severe mental illness. This is something we have to think about, Is the care of the people with severe, the care of people with severe mental illness is not something that is covered by private insurance or people who have jobs. It's a public matter. And we had to think like that because this is something that is very political in a way. So we have to think about that because whatever happens in the improvement of the care of these patients is going to be impacted by the politics, So I'm not taking one side. Whoever wants to help, Republican or Democrat, they are welcome, We have lack of residential treatment and lack of residential care. So we close the asylums, but do we have residential care? Are we interested in reopening residential care for the patients? Many people who are homeless, so they have an option to have some kind of residential treatment. If we are going to offer residential treatment, it's going to be a locked unit, an open unit. So these are things that should be in the debate of psychiatry and mental health care nowadays. We need more humane care. It's okay to do safety and prioritize safety, but also we have to keep in mind nurturance. If we don't do nurturance, we're not doing any treatment that is effective, so we had to really be careful with that. We had to conceptualize a more pleasant therapeutic experience. We have to consider maybe different kind of inpatient stays. Some inpatient stays for people who are highly suicidal, a different kind of inpatient psychiatric stay for people who are safer, where we can provide more nurturance, not design all the rooms for the sickest patients. There are rooms that can be designed for the sickest patient, and there are rooms that can be designed for patients who are doing better as well, and they have more access to workshops or being made the unit more open so that they can get out and come back for a couple hours, things like that we had to think about. Flexibility in the number of days for admission, of course, more public investment. It's never enough public investment. And I pay my taxes, and I'm happy to continue to pay taxes if it's for something that is going to be useful. I think most of the people in society wouldn't disagree with taxes going to mental health care. I mean, I think it's something that is meaningful for society as well. More independence for revenue from the market, from billings, from insurance companies. We're always litigating with insurance companies just to get reimbursed. This is a burden in psychiatric care nowadays. Also having more time to provide more quality care. I mean, is a 15 minutes visit something that is effective for nurturing? It's something, sometimes we have to fill scales and do many things and documentation. People are doing a psychiatric appointment now just writing on the computer during the entire psychiatric appointment. Is that the kind of psychiatric care that we want to provide? These are many of the questions that I want to raise for debate today. So we can do the best we can with what we have, So I have 30-minute psychiatric appointments. I try to do the best I can do with psychotherapy in those 30 minutes. I try to not be writing on the computer. I try to have a more conversation with the patient. We can try to do our best with what we have. We are not naive. We don't want to change everything, but also individually, rather than we can argue at the public level, but in our space, in whatever we are given, in whatever time we have, maybe we can try to do less documentation or document what is really needed and spend more time with the patients. Those are things that we can do at an individual level to improve the quality of care for the patient. I think this is my presentation for today. Thank you so much, Dr. Crane. Thank you so much, Dina and Oscar and everybody in the Global Health Symposium Committee. And thank you so much for your attention. It's been very nice to be virtually back at Ross for one day.
Thank you so much, Dr. Forson. That was incredibly informative. So I'll start it off. I have a couple questions, and then please, for the audience, please feel free to get your questions here in the chat, and I'll read them to Dr. Forson. So actually, I have two questions. I'll start with the first one. So I was really struck by one of the slides that you showed early on with a picture of the releasing the insane slide back into the community. And particularly struck by the expressions of some of the audience who was there to witness this release, and the body language and the facial expressions really kind of imbued with horror at the release of these people back into society. And this really kind of goes to stigmatization of mental illness. And I think it's probably fair to say we've made some advances in that since that time, but it's also fair to say that stigma still is pervasive. Even given our current understanding that mind, body are one unit, and that mental illness is a part of the illness that truly shouldn't be separated, but the stigmas remain. So I guess the question is, what do you think we could do? What steps need to be taken, both individually and at a societal level, to continue to reduce stigma around mental illness?
Yeah, I think the stigma is it's great that you mentioned the word insane, because it's true that now it's seen as negative. And in psychiatry, one of the things we are trying to do to decrease the stigma is to change the words all the time. So if I use the word insane from a historical perspective, that was the word used at the time, and it was not considered a negative word. But now it's considered a negative word, so we try to use mental health. So this is something that society is always changing, and one of the things they try to do to decrease the stigma is to change the words. So now, for example, some people don't want to use the word psychiatry anymore, and they want to use the word clinical neuroscientist, but that's a little bit tricky. You know, some people don't want to use the word schizophrenia, and they want to use the word Concord syndrome, which is cognitive young onset with other symptoms. So people try to change the words all the time, but that's a little bit tricky as well, because, for example, if you change in Japan, they change the word schizophrenia for mind split disease. And then in the newspaper, a lot of negative articles about bipolar increased. So society is still, you know, finding the ways to use mental illness in a way that is dangerous, you know, so they will use another diagnosis. So this is something that happens all the time. So we continue to change the words, but it's changing the words effective. It's kind of like tricky. Another thing we can do is advocate. And a way of advocating, in my opinion, and this everybody has a different opinion. A way of advocating is opening up, you know. So if I go as a psychiatrist and say, hey, I'm a psychiatrist and I wear my suit and I'm awesome and I'm not empathic and I'm a doctor and you guys should get treatment and this is because of his stigma, I'm not communicating with the audience, right? If I say, hey, I'm a psychiatrist, I have suffered myself from depression, I talk to a therapist, and I open up myself. I do therapy weekly, and for me, it's very helpful. So I tell the patients sometimes, I tell people, hey, I do therapy every week. I don't do psychopharm because I'm not that depressed or whatever, but psychotherapy for me is very helpful to, you know, get an understanding of my insights. So that's a way I think we can help to decrease stigma, is opening up ourselves, is talk about it, is sharing our experiences in podcasts, and try also to figure out what kind of treatment we want to provide. Because I think when the American Psychiatric Association says decrease stigma, decrease stigma, decrease stigma, but at the same time, all we are doing is 15-minute psychopharm appointments and misdiagnosing people. You know, if we don't identify our own problems in mental health care, I think it's very hard to decrease the stigma as well. So I think it's a multiple way of addressing it.
Great, thank you. And my next question is regarding sort of getting back to the patient that we started with at the beginning, and sort of to the disparities issue. So, you know, as a primary care provider here at Rush, which is, you know, a great hospital with great providers with a lot of support in many areas, I still can, you know, struggle greatly to get my patients, in particular patients who have public insurances, in for psychiatric and psychological care. And this isn't one of the best systems, you know, around. And so I wonder what your thoughts are about both the sort of public policy level and at a local level, what we can do to better advocate for care for those who don't have, you know, the direct resources or the insurance to get them the care that they need. And of course, I say it's a self-fulfilling cycle. The less you have, the less you have, and the cycle continues to perpetuate itself. So I know that's a really big one. There aren't any super easy answers to that, but it's definitely a struggle. And I wonder if you have any thoughts.
No, I think this is the same question. Everybody has a different opinion about how to deal with this situation. I think most people agree on having more public health investment, especially in the physicians world, especially primary care. People are like, we need more psychiatrists. What can we do about it? We need to refer these patients. These patients are not doing well, and there is lack of access. So we are training psychiatrists, but most psychiatrists nowadays are going to private practice. And if you look at the numbers, most people are going to private practice, and most people are not even working with insurance. I mean, half of my colleagues are just working with out-of-pocket because the salaries of the psychiatrists is lower. You can make more money doing out-of-pocket. If the public system is not going to pay you enough, people just advocate for themselves, you know? So this is what happens. So one thing could be more public health investment, and I think everybody advocates for that. But also, as psychiatrists, what do we want to do? We want to encourage people to continue to go to private practice and get out of pocket and preach about the stigma, but they're still going to private practice and getting patients who can pay out of pocket only. So now I work in an inpatient psychiatry unit, and people tell me, how do you get pleasure from this? Like, the patients never get better. They don't have insurance. They are homeless. They never get much better. But I say, well, this is what psychiatry is about. Psychiatry has always been a public health issue. So here I feel I'm doing something more public. So I find meaning into this. But I think at the same time, psychiatry is very politicized. So it sounds like the Democratic Party has allied with psychiatry, and they are together trying to increase awareness, and the Republican Party is more or less interested. At the same time, society sometimes is more worried or less worried. So we can increase awareness so that society gets more understanding, because everybody has people in their lives who have mental health problems. But at the same time, we should try to get the two parties working together. We shouldn't make psychiatry. One thing that I see in the United States is the Democrats care about psychiatry, the Republicans don't care about psychiatry. Most of the psychiatrists are Democrats. I don't think this is a good thing for psychiatry. I think psychiatry shouldn't be Democrat versus Republican. I think psychiatry should be Republicans and Democrats working together to improve mental health care, So I think that could be a way to think about it as well.
Great, thank you. So I don't see any questions in the chat.
There are questions there, as well as in the Q&A.
Okay, I can't see anything, so if you have something, you want to read it?
Yeah. So for the Q&A, this one came first. This is an excellent presentation, especially the potential for integrative medicine for minoritized communities, as well as a model for empowering culture and holistic behavioral health and substance use care. This was my doctoral minor. Can you discuss in what ways your work has incorporated these types of practices, and for what groups? Have you found National Center for Complementary and Integrative Health receptive in funding for these? I think that's the whole. Practices. Yeah.
Yeah, no, this is very good. And I see a question here on Santeria. So folk medicine is becoming more and more popular. Psychedelics are seen in a way as folk medicine, but also they are considered orthodox medicine as well, because we have some studies. So I think we're going to see it more and more, but homeopathic doctors are the ones who are really advocating for this kind of care. And sometimes we work with homeopathic doctors. So I'm working with homeopathic doctors in some, I have patients who have homeopathic doctors as well. But I think as psychiatrists, we are trying to incorporate this as well. So for example, I do fish oil, which there are also, fish oil is not homeopathic, it's also orthodox medicine. Psychedelics, we have a ketamine clinic here, and we're trying to do, I'm doing a research study here that we're going to add psychedelic psychotherapy to the patients taking ketamine, especially the ones taking higher doses of ketamine for depression. And I think here we have the depression treatment research program, and we are trying to incorporate all these things. Like, for example, saunas, like hyperthermia from sauna, like going to the sauna, that is something that is been shown very helpful for depression. We were not studying that. So in Germany, they are studying it. Here, we are doing a study now of just causing hyperthermia for patients. So I think there is a demand in society of getting treatments that have less side effects and can be effective as well. Because another problem we have in psychiatry is that we haven't defined the problem very well. Like, we don't know what depression is very well, because some people seem to be very sick, other people seem to be just stressed out. So we haven't defined the problem very well, and we try to provide the same treatment for everybody. But I think going to more folk medicine that have less side effects, I think that's something that society is asking for it, and we are trying to incorporate it more and more. So I find myself recommending probiotics. I find myself recommending eating salmon, doing fish oil, doing physical activity. So all those things I incorporate more and more. And I have patients who don't want to take lithium carbonate, and they want to try lithium oradate, which is what the homeopathic doctors recommend. And there is only one open label trial. So I try to look for the evidence, and I try to say, okay, just try lithium oradate from your homeopathic doctor, and let me monitor you more carefully. But I think integrating folk medicine is something that the orthodox medicine and folk medicine were separated, And now in America, they are being more integrated, and I think it's having a positive impact in medicine and in mental health.
There's another question, which was mental health included in the Affordable Care Act, if you happen to know that?
Yeah, it was included in the Affordable Care Act. And one of the things they did is that you could pay, that all the insurance had to have mental health care coverage, and the maximum of copay was $40.
Okay, there's an additional question here. Do you have some thoughts about why there seem to be a shortage of psychiatrists? Are there barriers in training that prevent students from going into psychiatry?
Well, before when I applied to psychiatry the first time, at the year before I applied, there was a shortage of medical students interested in psychiatry. They had openings of people who just didn't want to. I mean, they had openings in the training programs that were vacant. And then very quickly, psychiatry became more popular. And I think it became more popular because of quality of life. But part of the reason psychiatry is being marketed is because you can make a good salary for yourself being a psychiatrist. And I understand people want to pay their loans, which is another problem. You know, you have a big loan, you want to make a good salary to pay your loans. So that's how psychiatry is becoming more popular. But for a public mental health perspective, that's not a good reason for psychiatry to be popular, because in the end, you're going to find yourself working only with private insurance. So you're not going to, I mean, most people who are working in out-of-pocket clinics or private insurance, they are not seeing people with severe mental illness. So I think this is a barrier that we have discussed. And I think there are no barriers for people to apply to psychiatry. I think psychiatry is very popular nowadays. I think the problem that we have to do with psychiatry now is to figure out how can we train people well in psychiatry. And for that, we had to learn very good psychiatry ourselves and also be humble to understand where are the limitations of psychiatry, because psychiatry is biopsychosocial and it's very difficult to understand fully. There are more questions than answers in psychiatry. So we had to learn psychiatry, get disappointed at some things that are happening in psychiatry, fall in love with psychiatry again, but in a good way, and then try to define treatment that is helpful for the people and for society, you know, and also helpful for ourselves, because we had to take care of ourselves as well. But I think Rush, 10% of students apply to psychiatry, so I think psychiatry is not a problem for psychiatrists. It's a problem for people who want to be psychiatrists, and they unfortunately they have a hard time. I mean, for me, I had to apply twice in order to get accepted in psychiatry. So I think it's difficult sometimes. Yeah.
Okay, I think we have time maybe for one more question. Many of our chronically and persistently mental ill end up in the jail prison system. What can we do to systemically intervene or at least support this extraordinarily vulnerable population?
That's a great question that I didn't talk about it for limitations of time, because it would be a whole different presentation. But most people argue that closing the asylums is directly correlated to the number of people with mental illness going to jail. I would be a little bit skeptical to this statement because it's been reproduced in newsletters over and over again. Closing asylums, people going to jail, people in jail are people with severe mental illness. There is a correlation, but I don't think it's a direct correlation, because when you go to jail and there is a rotation for psychiatrists in jail, you see a lot of people who have mental illness, but that doesn't mean that they should be in a psychiatric hospital, that they are fully responsible for what they committed, and an insanity defense wouldn't have worked there. There are also some people who have mental health problems, but they don't have necessarily severe mental illness. And also there are people who have severe mental illness who, in my opinion, should be in an asylum or in a psychiatric hospital rather than being in jail. So I think the three things are happening. So one of the things psychiatry is trying to figure out is, should we do jail psychiatry, like a new fellowship and a new expertise for psychiatrists? And this is where some forensic psychiatrists are trying to go. But I'm a little bit also skeptical about that one as well, because we are encouraging people with severe mental illness in jail. I think people with schizophrenia or severe bipolar shouldn't be in jail. I mean, that's my opinion. But other people don't have severe mental illness, and they are trying to build the argument of having severe mental illness. So I think this is a debate that we have to raise in society, that is, poorly discussed, and we should discuss it more, because sometimes people take one opinion and they are not flexible about that opinion. So I think it's a very good debate.
Okay, I guess one more. I guess we have a minute left here. Dina, there was one more question. Could you read it for us? I can't see it on my side here.
Yeah, there was a question about it is so hard to find inpatient psych for teenagers. They are being admitted to the pediatric floors where they sit for weeks until they can be placed in a site. Often they are competitive. Many nurses have gotten physically hurt because of altercations with the patient, even with security present. What is the solution? Also, they are wards of the state with no parental involvement.
Well, that's the same problem that we have been discussing throughout the talk. I mean, most inpatient child psychiatry units are closing, and they are closing because of lack of public investment into their admissions. So most of the inpatient child psychiatry units are taking only private insurance, and the ones that were taking public Medicaid or any kind of or no insurance, they closed down. For example, Lakeshore Hospital in Chicago closed down. Part of the reason is, like, in the Chicago Tribune, they were arguing that it was not good care. But I would argue, with the money that they were getting, they were doing the best they could. But of course, it was not as good as Lurie's children. I think just closing it down and not improve it or not replacing it by something better, in my opinion, rather than closing Lakeshore Hospital, I would have given more money to Lakeshore Hospital so that they can optimize the care of the children in Lakeshore Hospital. But they say, oh, look, the treatment that they get is not good, and most of the children there are African American, so let's just close it down. The government is going to be happy with that because they don't have to put money there, but nothing happened after that. It's just, now, where are the children going? They're not going to disappear. Are they going to go to jail? I mean, what is going to happen? So these are the kind of questions that we have been talking over and over again. I mean, most inpatient child psychiatry units are closing, and not only child psychiatry, like Jerry psychiatry units are closing as well, because it's Medicare. So Medicare pays less than insurance. So they are going to close down unless Medicare wants to pay more for their hospital stays, because the hospitals are not going to find it feasible from a financial viewpoint. So I think it's a public issue. I mean, like, I'm happy to pay my taxes for this, but it's a public issue, and we have to address it as a public issue.
Okay, thank you. Thank you so much. This was really a fantastic talk, and I think it lays a great foundation for the rest of the week. And just to remind the audience, we do have talks the next several days through Thursday. They're going to be addressing specific actions that we're taking both at a global and a local level to decrease disparities and increase access for patients. So this, again, was a great foundation. We thank you so much, and thank you very much to the audience, and hope to see you again tomorrow at 12. Thanks, everyone.
Well, thank you very much for your attendance. I hope to see you soon.